to the second day of the CHSPR virtual conference. We're doing things a bit differently this year. So welcome back to those of you who have joined us, and we have a really great afternoon that's starting, and I just wanted to make sure that I am thanking our sponsors, because without them, we wouldn't even be able to do this. So I want to just have a shout out to the BC Patient Safety and Quality Council, the BC Ministry of Health, the BC Academic Health Science Network, the Canadian Institute for Health Information, the Michael Smith Foundation for Health Research, and Healthcare Excellence Canada, which is the brand newly amalgamated organization that brings together the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. So without further ado, I'd like to turn it over to Dr. Kim Mcgrail, who is your session chair this afternoon. So please, Dr. Mcgrail.
Fantastic. Thank you so much and welcome everybody. Either welcome for the first time this afternoon or welcome back if you were with us yesterday. I'm Kim Mcgrail, and I am a professor in the School of Population and Public Health and with the Center for Health Services and Policy Research. And I'm really pleased to have the opportunity to chair the session this afternoon. So we have two speakers with us, Professor Tim Tenbensel and Mary Bakash. And so I'll introduce our first speaker and then we'll get us started right away. So just a brief introduction. For a fuller profile, you can see the information online. But Professor Tim Tenbensel is an associate professor in the School of Population Health at the University of Auckland. And he has a broad range of research interests, including health policy, implementation, performance management, primary health care, comparative health policy, and of course, integrated care. So he's going to be talking to us about the do's and don'ts of nurturing local collaborative capacity to support health sector integration, reflections on recent experiences in New Zealand and beyond. So with that, over to you, Professor Tenbensel.
Thank you. I'll just share my screen and hopefully that is looking okay. If Joyce can let me know whether that's working. Okay, great. And I just need to set up a couple of things on my screen. So, kia ora koutou. Greetings to everyone from Tamaki Makaurau, the Rohe, the tribal area of Ngāti Whātua in Aotearoa, New Zealand. It's a pleasure and an honour to be invited to give this presentation at CHSPR. I really enjoy interactions with CHSPR that I've had in the past. And it's been very exciting to hear the ongoing conversations that you're having about integrated care. What I'm going to do today, rather than talk about the do's and don'ts, inevitably that will follow, but Stephen Lewis, right, as we were preparing this conference, asked me if I could sort of think about necessary conditions for interorganisational collaboration. So that's what my main focus is going to be, particularly towards the end. But I want to start by picking up some points made by Walter Wodgis yesterday. In his presentation, he emphasised the bottom-up nature of integrated care, and in doing so, he also stressed that the system or policy and organisational layers provide favourable or unfavourable conditions for specific integrated care initiatives. So in this presentation, I'd like to take that idea a bit further. I want to concentrate on what happens primarily at the organisational level, or particularly the interorganisational level, and ask what are the conditions that support interorganisational collaboration in order to support integrated care. So my training and background is in political science and public policy, and my central research interest has been policy implementation in the health sector. And interorganisational collaboration has been a common denominator in most of the work that I've been involved in. Integrated care requires interorganisational collaboration whenever multiple organisations are involved, and that is most of the time. This doesn't mean that where there is good interorganisational collaboration, integrated care systems will inevitably follow, but it does mean that integrated care systems often fail to flourish where interorganisational coordination is weak, or collaboration is weak. So the key question for me today is, what are the conditions that nurture interorganisational collaboration over the long term? And in answering this question, I'll draw on a number of research projects I've been involved in, primarily in New Zealand, but with some experience in Canadian settings. So I view the survival of interorganisational collaboration in healthcare as analogous to the survival of green sea turtles. Now, they lay a lot of eggs, over 100 at a time. Not all of these hatch, and of those that hatch, many hatchlings don't survive. And there are many hazards that a young turtle must negotiate before they become mature. So successful interorganisational collaborations in health are both impressive and probably relatively rare, considering that many collaborations never hatch or survive infancy. Okay, so it's crucial to remember in countries such as Canada and New Zealand that health is a key domain of public policy and public sector management. So it's really important to understand how the policy and public management environment supports or doesn't support interorganisational collaboration. So this is like the ocean that our green sea turtles swim in. And this ocean can be healthy or toxic or anything in between. But the second key point is that healthcare services for interorganisational collaboration is predominantly a local matter. And this means that whatever is happening more broadly in the policy environment, most of the action is still local. Or to put it another way, within the same broad conditions in the ocean, interorganisational collaboration prospers in some places and not in others. So we can find out a lot about interorganisational collaborations and the conditions that support it by looking within a particular province or a particular country. Now, interorganisational collaboration in health is quite a common thing, and it's not just about integrated care, as I've mentioned. Generally, much of the work in establishing and maintaining collaborations is done by middle-level managers and clinical leaders, particularly when large organisations are involved. And these people often face different sorts of challenges depending on the overall local environment they're in. If they're lucky, they'll be working in an environment that supports integrated care, and here that's depicted as a fully closed or integrated ZIP. It could be a situation in which frontline providers are integrated, but there is significant fragmentation at the organisational and policy levels, and that's the second sort of ZIP, the Y-shape. Or you could turn that upside down and say there's policy integration and organisational integration, but fragmentation at the local level, at the provider, at the level of care. But finally, and I think this is a common situation, there are many attempts at interorganisational collaboration where managers and leaders are dealing with the situation depicted in the third ZIP, which is there isn't support from above or below. Okay, so that's just some introductory notes. Now I'd like to just focus a little bit on why you might be interested in looking at New Zealand or things we've learnt from New Zealand. And there are some important differences between the Canadian context and New Zealand, but the similarities, I believe, are more important. So when it comes to talking about interorganisational collaboration, New Zealand's situation is more strongly shaped by the legacies of new public management, which you may be familiar with. And on the other hand, New Zealand is less constrained by the sorts of siloed funding arrangements that Walter referred to yesterday in his talk. They're still important, but they're less significant here. Another reason you might want to keep half an eye on New Zealand in the future is that if you're interested in integrated care, is that we are likely to be introducing major policy reforms that involve providing some integrated purchasing capability for a Māori health authority. I'm aware of what's been happening the last few years in British Columbia with the First Nations Health Authority. What might be happening in New Zealand may be at a much larger scale. So now I want to talk about the sorts of research projects that I've been involved in. All of these have some connection to integrated care, but some more directly than others. So the first project in the list, the most recent one, we've studied the implementation of a Ministry of Health initiative in New Zealand that's aimed to facilitate and build local capacity for integrated care, quality improvement, and addressing of healthcare inequities. So this involves fostering interorganisational collaboration between our public sector district health boards and our non-government primary health organisations. And in our research, we looked at what happened in 18 of New Zealand's 20 districts. So we got a very broad overview of the successes and failures and the grey areas in between. The second project, Walter and Carolyn both referred to yesterday, iCoach, and I was involved in the New Zealand branch of this, but also became familiar with some of the Ontario cases in particular. Now, one of the New Zealand cases is world famous in integrated care circles. That's the Canterbury region, centred on the city of Christchurch. And it's famous for its approach to integrated funding, service design, and information systems. The third piece of research was of an interorganisational initiative a few years back in the city of Auckland. And Auckland, in contrast to Christchurch, is well known for its fragmentation and relatively poor relationships between the key health sector organisations. So this initiative involved the creation of a network connecting emergency doctors, primary care doctors, nurses, after hour clinics, and the organisations within which these were located. And finally, the fourth one, I've spent some time in Ontario over the past 6 years looking at Ontario Health Links, which, as many of you know, were designed to develop integrated care for patients with multiple chronic and intersecting conditions. So I've been connected with Walter Wodge's team in the overall evaluation of Health Links. So in terms of the rainbow of integrated care, my research covers the range, but I guess the centre of gravity is the middle. Now, before I go and talk about the conditions that nurture or support interorganisational collaboration at the local level, I just want to get back to the issue of public sector environments and public management environments. We need to look at the broader public policy ocean before we can think about the local conditions. And now there's been an enormous amount of research and practice across all fields of public policy across the world, extolling the virtues of collaborative approaches to public policy and implementation. So healthcare is far from unique. And it pays to look at some of the more general debates that have been going on about the virtues and vices, if you like, of collaborative governance or collaborative management. I won't spend much time outlining the virtues because they're similar to what's often suggested in healthcare. So the idea is that public value can be co-created and co-designed, or should be, because no one, particularly no government agencies, knows everything, but everybody knows something. Or that collaborative approaches often lead to much more successful implementation because people are involved in the design. Now, collaborative management is a contrast to some more traditional ways of public management, particularly traditional hierarchical or bureaucracy management, or more recently what we've called new public management, which involves a lot more hands-off contractual relationships. Now, in these broad debates, all I want to focus on is that collaborative public management does have some well-known downsides. And the most obvious is the amount of time and energy and sometimes money that it takes to build collaborative capacity when participants don't always have a lot to spare. That's important. A second important one to always be aware of is around issues of legitimacy. Now, collaborative approaches often run counter to what many people regard as good governance and management, partly because they dilute clear accountability, because they are collaborative. They often also might run counter to public sector practices that might require transparent reporting or contestability of funding. And thirdly, in this issue of legitimacy, they might inevitably, collaborations, in order to be manageable, often end up excluding some stakeholders, some relevant stakeholders. And related to that is the issue of power. We shouldn't also forget that collaboration can often serve to entrench existing power relationships, even when they are innovative. And finally, there's complexity. There are so many issues, problems, and aspects of health services that could warrant collaboration or collaborative activity. And if many are attempted at the same time, different collaborative initiatives will cut across each other. So for these reasons, not everyone is a fan of interorganisational collaboration, and public policy environments may be less supportive of it. So the ocean can vary from being benign to supportive, or it could be a bit toxic. So now let's get back to the local level and why things thrive, why collaboration thrives locally, or what are the threats to it. So I'll start with looking at the threats. And here I'm going to apologise for stretching the metaphor to breaking point and talking about things like parenting. I'm not sure how much parenting goes on in the world of sea turtles. But anyway, let's start. So bad parenting. What do we mean by this? Well, this is if a lot of the collaborative activity happens at middle levels of organisations, the key thing is what happens at the top and how much support there is from the top. And sometimes senior leadership in collaborating organisations show little interest in collaborations that are initiated further down. Now, there might be a lot of good reasons for that. These are highly complex organisations with lots of internal tensions and competing priorities. But at some point, most health sector collaborations face threats that require protection from senior management. Our iCoach examples in New Zealand all told relatively positive stories about senior leadership supporting collaboration. In our system level measures research, the most recent one, which we looked across all districts, the stories of parental neglect were common in districts where implementation did not get as far. Now, lack of parental interest also came up in some of our research in health links in Ontario. And sometimes parental interest can be unhelpful, the wrong sort of attention. So senior DHB managers in New Zealand are frequently very impatient to see tangible gains from collaboration in short timeframes. This is a bit like helicopter parenting, in which the pressure is on from a very early age to be a golfing or a violin prodigy. So in interorganisational collaborations, the parents often have unrealistic expectations, such as immediate reductions in emergency room admissions. Now, the second threat is potentially even more damaging. Conflict between organisations often has long-standing local historical roots. It's often because simply the same people have been around for a long time. It could be because one or more organisations has behaved badly in the past, or the coolness of relationships may be more institutionalised in public sector practices, as they are in many places in New Zealand. Now, our system level measures implementation research clearly showed that these factors cannot be overcome by middle level managers. This is akin to expecting the children to function well while the parents are fighting, or worse, expecting the children to fix or heal parental conflict. Thirdly, exhaustion is a common experience of those involved in establishing interorganisational collaborations. And in most cases, such networks are reliant on a lot of goodwill and emotional energy of a handful of participants, and burnout is common. Fourthly, many local collaborations work off very few resources for a whole host of reasons again. We saw this, I think, in the Ontario Health Links example. And the Auckland After Hours initiative, the network kept having to go back to its parents, its senior levels of the organisations in an Oliver Twist-like fashion to ask for more funding. There was no long-term sustainable funding for that initiative. In the system level measures story in New Zealand, we saw an interesting twist on the question of resources, in which some organisational participants had access to resources through the policy, while others didn't. And this is analogous to parents feeding one child but not feeding the other. More generally, it may be reasonable to expect the children of or the inter-organisational collaborations to acquire their own food at some point, but generally that's not reasonable while they are still infants. And where collaborations are reasonably resourced, it's often common in health organisations for people to say, hey, this money should be going directly to services. If the resourcing is visible, it is also vulnerable. And few collaborations are hardwired into organisational budgets as non-negotiable things. Now, amnesia is the next one. What I mean by this is inter-organisational collaborations are also at risk of falling over when key staff leave. And this is quite common in collaborations in larger urban areas, particularly where there is lots of career mobility in public sector organisations. So when key staff move on, those that remain end up having to invest new resources in developing new relationships with new staff. And finally, a key reason that collaborations don't survive is because they are deliberately killed. So there are predators. In the Auckland After Hours initiative, this was effectively killed by a single individual, basically, who never accepted the legitimacy of the network in the first place. You may be saddened to know that the well-known Canterbury Clinical Network I referred to earlier has recently suffered some life-threatening injuries inflicted by central government agencies. Happy to talk about that later if anybody is interested. Okay, so with all that as a preamble, I can now address what I think are the necessary conditions for nurturing inter-organisational collaborations. So here's my best attempt. So I want to reduce it to 5 things. So the first is to provide shelter. And what I mean by this is that it's the other side of the coin of what I referred to earlier. I think this works best where there is some formal agreement at senior levels of participating organisations that provide protection for new collaborations and prevent them from being picked off by predators. So in New Zealand, the device for doing this has been what we call district alliances between district health boards and primary health organisations. Essentially, that's a formal shared governance arrangement. And this was crucial and central to the Canterbury example. In fact, it came from the Canterbury example in New Zealand. So all districts are required to have district alliances, but then again, not all of them are actually real or functional. So where these alliances were real and functional, mid-level managers do feel protected and supported in their collaborative work. Okay, the second necessary condition, I believe, is good parenting. This doesn't mean the parents have to agree on everything, the senior levels of the various organisations, but they do have to be able to respect each other in order to productively deal with differences. So in our system level measures research, the clearest difference between those districts that picked up the challenge and those that didn't was the health of inter-organisational relationships at senior levels. Where collaborations had supportive leadership, they were able to deepen and widen collaborative capacity and take it into new areas. But where these conditions were not present, the good relationships between middle level managers did not overcome local histories. Thirdly, our baby turtles need food. So localities with a history of longer lasting collaborative relationships in New Zealand share one important characteristic. They all were based on the use of seeding money to get the collaboration initiatives and relationships going in the first place. There's some amount of luck involved there, but others in other places, organisations made a concerted commitment and sacrificed other things in order to prioritise collaborations. Number 4 on the list for nurturing local collaborative capacity involves information, and this relates to things that other speakers referred to yesterday, particularly Carolyn Steele-Gray. The system level measures framework grew legs locally where organisations had agreed to share utilisation data. This can generate a whole range of virtuous circles. Data isn't the whole answer, but it's often the key to starting new and productive conversations. The willingness to share data is often a great indicator of the trust levels between organisations. And finally, number 5, spread the collaborative load. Collaborations need to be part of organisational DNA rather than something that is just the responsibility of a small number of individuals. Okay, so that's the main message, but just a couple of one particular thing that I'd like to add, and this is about the connection between integration and collaboration and equity. So some speakers have said that true integration involves equity, and I agree. But it gets a little bit more complicated when the focus is on interorganisational collaboration. So I don't think the link between collaboration and equity is necessarily all that strong. It all depends on who is in the collaborative tent. So collaboration can easily entrench patterns of marginalisation, colonisation, and power divergences. So in New Zealand, I haven't yet seen examples of local collaborations at the whole system level in which Indigenous providers of health services are central players. They are often peripherally involved, but a common comment I've heard in research is, yes, but if it was a true collaboration, Māori would be involved in defining what the problems were in the first place. And that would have significant implications on which organisations were central to the collaboration. And this comment applies perhaps even more so to relatively successful collaborations. So it all goes to emphasise the point that good interorganisational collaboration at the local level is an enabling factor for integrated care, and a crucial one, but maybe, of course, not sufficient in itself. If individual organisations don't have a track record for prioritising equity, then why would we expect collaborations to? So part of the challenge of this talk was to try and identify sufficient conditions as well as necessary conditions. And I want to finish by ducking out of that one, really, basically. And I sort of want to go back to our analogy of sea turtles. What's a sufficient condition for a sea turtle to survive to adulthood? And I think a certain amount of luck is always going to be involved. If you have the necessary conditions, there's no guarantee that you are going to survive to a ripe old age. So I really think the key question is what can be done to increase the chances of more collaborations surviving? And how do we establish more permanent cultures of interorganisational collaboration at the local level? So I'll stop there, and I'm interested to hear people's questions and see if some of these experiences resonate with what you're experiencing in Canada. So thank you.
Thank you so much for that. Those comments were, there's so much in what you've said, and I really hope that there will be lots of questions. And just as a reminder on that, please do use the Slido system for putting in your questions and then voting or upvoting other people's questions. And Joyce put a link to that in the chat, so you can find that easily. So I am going to move us now over to Mary Bakash, who is going to be providing some additional comments and her perspective on this. So just a brief introduction. Mary is actively involved in educating and advocating in matters of Indigenous health, patient partnership, chronic kidney disease research, and organ donation and transplantation awareness. She's co-chair of the CanSolve CKD Patient Governance Circle and the Indigenous Peoples Engagement Research Council. She is at Anishinaabe and lives in our home community of Nipissing First Nation. And so welcome, Mary, and we really look forward to your comments.
Thank you. Good afternoon. I liked your analogy of the turtle and the parenting it puts it in a really relatable sort of flow for me anyway as a patient partner. I have my own experiences in terms of integrated healthcare, and you sort of touched a bit on. I'll speak first from an Indigenous point of view. Talking about how that integration happens and how that how it flows, and it's really interesting because not only do we have healthcare from a federal perspective, but we also have healthcare from a provincial perspective. And sometimes it's really hard to get everything to match. And I'll just use a quick story. I had a transplant 6 years ago this month, a kidney transplant, and it was a living donor. My cousin donated to me, and she lives in northern Manitoba, and I live in northern Ontario. And so we had the transplant in Toronto. And there was a lot of bureaucracy in getting us to that point. It took almost a year not for us, but for the three governments, the two provincial governments and the federal government, to figure out kind of who is paying for what and who is taking care of what. And in that time, I'm waiting. So as you were speaking, I was thinking about, you're talking about the growth of the integrated care and things like that. But then in the meantime, as that's growing, the people who need it are still sort of going through what they're going through and having to process that as well. So it was just, it just kind of brought that thought to me, and just, and also too, in your comments towards the end, talking about having the right people in place, and being careful with that collaborative and that equity piece going together. Sometimes the equity happens when you have the right people there, and if you're not including Indigenous representation in those conversations, you're not going to find out what's needed. But I also too, as a patient partner, I've had experience in seeing the implementation and the growth of Ontario Health, for example, as an organization. We've had a political switch, and things are being revamped, and it all just started, and then COVID hit. So not only are we dealing with organizational change, we're also dealing with a pandemic. And some of the things that you talked about in terms of turnover and not nurturing, and I mean, it's just sometimes it's just part of the nature of the beast, I guess you could say. But also too, I could see those things happening, and seeing that course correction happening now, where we're sort of slowly starting into a recovery mode. So it's just really interesting to be able to witness that from a patient being involved in different groups and organizations through Ontario Health, kind of like an outsider looking in, but just sort of getting a brief understanding of what's going on. Integrated health, yeah, it can be tricky too, because I can see where that feeling of territorialness, or this is sort of my space, not your space, and those things all have to work. We have to work through those things, and it's all growing pains too. So those are things that really sort of resonated to me at this time. And I'll leave it there. I don't know if we have any questions, and maybe we can go from there.
Thank you so much, Mary. You've given us a good start, I think, and there's lots of questions coming in, and I hope you keep them coming. So I will perhaps direct some of these, but since there's just two of you with us on this panel, I think please both of you feel free to comment on things as you wish. So Professor Tempenzel, what provider incentives have been used in New Zealand, if any? And if none, do you think they have a role to play in establishing integrated care networks?
Yeah, great question. and sort of some of this sits in the background of some of the things I was telling about, and I didn't really want to go into any of the details of particular policies. There are some, and particularly at the primary care end. I mean, the paper that Walter Wood just referred to yesterday, basically what the argument we said was basically there is actually lots of scope for integrated funding in the New Zealand system, but it isn't often taken up. But there are areas, for example, our primary health organisations have what they call a flexible funding pool. So these are sort of consortiums of mainly general family physicians, but also other primary care providers. So they can often incentivise particular new sort of integrated care initiatives, and many of them do that. They're often very small scale. So there's plenty of scope, and there's also plenty of scope for our district health boards to fund things locally, and that's what the expectation from government is. But of course, there you run into the usual problems that most of the district health board, given that they run and control the hospitals, is already, is 99% accounted for, and the level of discretionary spending that they think they have is characteristically very small. So the room is there. There's nothing to stop it, but it doesn't happen as much as it should.
And Mary, did you have anything you wanted to add to that question, given all the experience you have looking into the system?
No, I didn't really have anything to add to that comment.
Okay, so let's go to the next one. So the next question is definitely, we'll start with you, Mary, is what role should patients play in these processes?
I think ultimately you have to really be your own advocate. You really have to know, what's going on with you, and you can't be afraid to speak up. And I mean, some of the experiences that I've had in supporting other patients, even for example, is just having that level of confidence where you feel that it's okay that you can say something about what's going on. Some are sort of passive in their care and just, and don't realize that you might be the conduit to bring everybody together, even in an integrated setting. You're sort of that common denominator when it comes to your own situation. So in that regards, I think that's what your role could be. If you can get involved in any other sort of advisory organizations and things like that too, if that's something that you're interested in, I think it's really important to bring that perspective, your stories, and things like that as well, because that helps shape the process. Sometimes you end up falling into a situation where you can help co-build something. And I think it's important to take advantage of those situations when you can.
Tim, did you have anything you wanted to add?
Yeah, I mean, one recent development, and I think we're quite behind on this in New Zealand, is the development of patient councils or local groups representing patient voice in local decision making, and it's starting to happen. But in my most recent research that I did across the country about the system level measures project, not once were patient groups identified or recognised as participants in the sorts of conversations that we're having in this policy. And yeah, I think that's a fairly typical story. So yeah, I think that's where things have got to go. And then of course, then you get into the issue of the representativeness of these patient groups, and hopefully you're not just getting the articulate ones that already benefit from the way systems and services are designed. So those things, we're in very early days of those conversations here.
So I'm going to push this just a little bit, because I mean, I think the answers that you've given are really, really interesting, but they do operate at two different levels. One being the patient voice for identification of issues or policy setting or that kind of input. And then I think where Mary, you started talking about the patient voice as a self-advocate in the system of care itself. And I would love to hear either of you comment on whether we the line, the balance we need to achieve between helping people be their own advocate and expecting them, because our system is so broken, that they must play that role in order to help the system do what it should be doing. Like I think there is a line there, but I would love to hear if you have any thoughts on that.
Well, in regards to patient groups and things like that, I think I've become a co-chair with the CEO of Ontario Health with a patient advisory group for him, sort of get the landscape, because we've had like these local health networks that are evolving into something else, but we've had the co-chairs of these groups come in, and me being someone who's generally focused on CKD and transplantation, it's been really interesting for me to see their broader scope of what they talk about in terms of other issues. So I think if you get voices from different areas, and we've been really conscious about trying to capture those, like you said, those voices that might not speak, or those marginalized voices, or trying to meet people where they're at, because you do end up getting the same players that come along time and time again, right? So it's really important to try and flesh out those other voices. And some people won't speak, and that's fine. But I mean, there's people who want to speak, but maybe don't know how to take advantage of that opportunity, or how to get involved. And for personally, I don't know. It's just like you talked about that fine line, and I've heard patients where they say they've done their own research and things like that, and their doctors are coming to them and asking them about stuff. But I mean, that's sort of a slippery slope too. It's just I've seen where people not passively let things happen, but they're too afraid to ask a question in the moment, or they haven't absorbed it, and they don't feel that they have an opportunity to ask it again. I don't know. It's just, I still say, even if you can't be your own advocate, you need somebody there to be with you, whether it's a family member or a navigator or something. I just know from my own experience, and I'm thinking of a family member right now who's going through this, advocating for her son. You can't help but be aware, and you can't help but speak up when you need to. It's just, it's not a trust thing. It's just that you can't just let things go passively.
Yep. Tim, anything further to add before we move on?
Yeah, only thing, and it's not really related to anything I said, but is clearly, this word patient persists, and patient is a very passive term. And clearly the way the system was set up was the expectation that patients would be passive. And so this is not, that's pretty hardwired into the way we talk and think about healthcare.
Thank you for those comments. So next question here is, would you differentiate between networks and inter-organizational collaboration?
The short answer to that is not really, no. I guess I just had to choose which one of those to use. And so I chose inter-organizational collaboration. But I think we're talking about the same thing. I guess there's a lot that's been talked about networks, and sometimes networks can be very diffuse, and not involve a lot of commitment, and you can still be involved in a network. When people talk about collaboration, generally, I think talking about more close knit, sort of relationships between organisations. There's a lot more at stake, I guess. So that might be a subtle distinction to make, but a minor one.
So the next, Professor Tempenzel, you mentioned sacrifices have to sometimes be made to fund collaboration initiatives. What types of sacrifices have you seen to be effective?
Okay. That's a very difficult question to answer. I can sort of really only answer it in very general terms. It sort of goes back to, I think in the New Zealand context, I guess our district health boards are equivalent to your, what you would call local or provincial health authorities. They, when something is funded, it's really difficult to tell where that money comes from or who's not getting it because something is funded. But one can presume that sort of it may be sort of resisting pressure to sort of provide sort of increases in operating budgets in the hospital system, for example. I would expect that may be a common story where this is done, but it's not done that often. And we know over the last 10 years that in New Zealand, if you look at the health budget and you look at what's gone to hospitals and what's gone to community-based care, the force of gravity is still very much going towards hospitals. So, our district health boards, those that did it about 15 years ago, and not many have done it since. Sorry, I can't be more specific in answering that question.
I really appreciate you bringing up the relationship between the institutional or acute care sector and community-based care, because that resonates with some of the issues we've talked about, and of course it's a prime spot for integration, or where integration should be happening as people move across those systems, and it does seem that the force of gravity, as you say, still rests with the institutional sector. So I wonder, Mary, if you have any observations about that or experiences that kind of reflect or that resonate with that.
I'm trying to think of something, but I don't, unfortunately.
Okay, so let's the next one then. How much does evidence of the value and impact of inter-organizational collaboration play in the choice of leaders to undertake collaboration?
Oh, that's such a there's such a lot to that question. There's so many ways we could go with it. Sometimes, okay, so I'll step back a bit and say sometimes people who want to sort of move towards more collaboration between organisations will make arguments like this will mean better health outcomes. This will have this sort of measurable benefit. And while that I think is often true in general terms, the difficulties of actually demonstrating that and proving that are enormous. Partly because the sorts of outcomes people are interested in are so multifactorial and not necessarily sensitive to the particular interorganisational initiatives, to what people do. So you have to be really careful of raising expectations unrealistically and sort of saying, well, there needs to be evidence before we do this. Yes, of course, there's going to be evidence in particular areas, particular service areas that might be useful, but in general, my experience is that it's extremely difficult to sort of pin down that evidence. Doesn't mean that these things are not working or not effective. It just means it's extremely difficult to pin it down. It's easier in some areas than others, but generally really difficult.
So I want to pick up on this one again, and Mary, I'm going to warn you, I'm going to come and ask for some comments from you. But what I want to pick up on is, I'm thinking back to yesterday. Well, so first of all, Tim, in your presentation, you talked about things being necessary but not sufficient, and it just feels like it's such a high mountain to climb. You have to have all of these different ingredients in place, and that still may not be enough. And I keep thinking about Walter Watches's comment yesterday about trust, that trust comes to you at the speed of a tortoise and will leave at the speed of a horse. And at the same time, how can we not expect and want interorganizational collaboration when patients themselves are moving across organizations in their pursuit of high quality care? So I will come to you first, Tim, and just ask, is there no way to recalibrate that idea of the necessary and the sufficient, and just make it, as you were hinting at, and it said explicitly at one point, about building this into the DNA of organizations? Is there any possible way to do that?
Well, I think ultimately when it happens, it's because people have decided to do it and decide to take up that challenge, but it's not necessarily an easy challenge. And I'm wondering whether I could sort of address the new public management question at the same time, because in the New Zealand context, that is often the significant barrier. The way it's a way of thinking that's hardwired, I think more so in New Zealand and Australia than in Canada, in my experience, but I don't deny that it's sometimes important in Canada as well. And so you really have to try and get beyond. So I guess one of the things about the whole idea of new public management is it's based on a foundation of distrust between organisations. So, we don't trust that you're doing a good job. You've got to prove it, and you've got to prove it in terms of the contractual. We've got to write it down in the contract, and you've got to meet those contractual requirements. And this is toxic, broadly, to interorganisational collaboration and anything that requires, sort of organisations to work together, because it actually breeds the distrust. So how to overcome it? Well, all I can say is that in some places it matters more than it does in others, and actually that sort of is through the local histories and how much people work around those constraints and conditions and the things that they've got to do, and do other things that they want to do, and they got to decide to do that.
Yeah, that's very powerful, but statement, but also really underlines the fact that we talk about our healthcare system, but it clearly is not a system. It is a network of systems, or something less than a unitary kind of being. And Mary, I'm happy to hear anything you might want to say, but I'm particularly I'll say that it would be interesting to hear your perspective from the patient side. Do you feel this interorganizational discord? Do you, and is there a way to change this from your perspective?
I just wanted to, before I get into like that interorganizational discord, one of the things I just wanted to say too, there's so many variables, right? And sometimes they want the proof before you even establish. And again, that talks to that toxicity that Tim was talking about, and just how you could follow the model of another collaboration and get a whole different result because the variables are different. But from a patient perspective, in regards to do you notice the difference? I find that, I think sometimes you feel it. You might not know what you're experiencing or what you're feeling, but yeah, you might find that shift, a slight shift in policy, or it was done this way, a couple of months ago, and then you go back and it's done a different way. And it may not just necessarily be the policy of, the organization that you're dealing with, or that part of the network that you're dealing with, but there's overall shift and it's being implemented. And you may not be aware that it's being implemented, but you're feeling the effects of it, right? And one of the things too, just even in terms of creating that sort of inter-organizational collaboration, and that talk about trust, and that's one of the things that we talk about when we're talking to non-Indigenous researchers or medical teams going into Indigenous communities, that it's going to take you probably about 75% of your time just to build that relationship and build that trust. And then you'll get that work done in the last 25%, but that too will run like a horse. But you have to do all of that work, and all of that work takes time and money and investment, but you don't see a lot of turn on investment in that either, right? So that doesn't fit necessarily into that Western sort of view of wanting to get results and get results now.
Yeah, so that the focus on relationship as part of in the work that I do with public deliberation, we talk about the difference between being trusted and being trustworthy. So you act in a trustworthy manner, and that helps to build trust. And I wonder sometimes if peeling those apart a little bit could help us understand how we build the relationships that are needed. So, in that realm, this next question, with all of the pilot projects that come and go, can patients get lost in the process? And I think we could talk about pilot projects. We could talk about attempted collaboration, whatever you wish, but is the constant experimentation potentially harmful?
I think it is. And I think part of that too is the fact that the perception of research in earlier times, where the perception was they come in, they get what they want, and then they leave, and then there wouldn't be that the circle would never be completed. They wouldn't always come back and let you know what the end result was, or even whether the research was completed, or what happened, right? So they get lost that way. And I think it's really important now too to have patients involved in, you may come into this community or this group or talking to people who are involved in these pilot projects with a certain idea of what you want to accomplish. But I think it's really important to get some feedback from patients to find out what it is they need. They're the end users of the network. They're the end users of these pilot projects. So I think it's really important to get that, whether you're prepared to do co-design, or whether you want feedback on making sure that you're going in the right direction. It may take time, but that time I think is well invested.
That's really, I think really well done. Go ahead, Tim. Sorry.
Yeah, I just think the issue of pilotitis, if you like, I don't know, we've heard that word. It's in the UK context they use it. Is, there's a couple of things going on there. It's like the turtle laying 100 eggs, I think part of the reason that pilots have become so prominent and also so problematic is, again, going back to the idea of sort of discretionary budgets in organisations. This might be how you stick a toe in the water, but unless there is some sort of commitment to institutionalise something after a certain point of time, then it just becomes in many ways wasted effort. And then the question is, what is the right amount of time? And what we know, and I think, and what I've seen a number of times, and I've just seen a really good Dutch example of this, is sometimes there's a waning of the initial wave of enthusiasm for collaboration kind of lasts about 18 months. And it's what happens in the next 6 or 12 or 18 months after that it ends up being really, really, really crucial, because it's not new anymore. It's not a cute baby anymore. And this is where a lot of collaborations fall over, because the senior levels of the organisation say, "Oh well, that was a previous manager who sponsored that one. I've got to make my mark in a different way." And so you see, you see the sort of, therefore, people in the collaboration know that the love isn't quite there anymore.
Mm-hmm. That lack of continuity can be pretty, destructive to the results of what happens to patients, right? It's not about the mark that you want to make. Ultimately, it's about how it's going to affect the patients. And I think sometimes that gets lost. That sight gets lost.
That's emblematic of a lot of things. So it's a really, really important point. And I like the stretch of the parenting analogy to think about programs having sort of a terrible twos or a trying threes kind of issue that you have to sort of get through if you want to get to the next stage. Okay, so next question: has virtual care been part of any initiatives either have been involved in, and if so, what were the successes and pitfalls of incorporating virtual care?
I can't really answer that, because most of the things that I've been looking at have been sort of more, I guess, further up the chain, not sort of the details of the service concerned. So I'm sure it's there in some things, but I just don't know. Maybe the closest would be the Ontario Health Links, and I think that'd be an example where it's really difficult to do virtual care as part of the health links, maybe, but just because I know that the links, the shared care plans, the coordinated care plans, in most places are on paper, which makes other types of interfaces perhaps more challenging. I could be wrong about that.
I can share something. One of the research projects that I'm involved in with CanSolve is called the Transplant Ambassador Program. And essentially what we do is we go into renal centers and we talk to patients. We've all either received or donated kidney. So it's a form of peer support. And it's all been done in hospital. And we work with the quality improvement teams with the hospitals. Like it's working towards being integrated, and it's working towards moving the needle on living donation. So the really key part of it is building those relationships with the patients and having those conversations in center, whether they're on dialysis or whether they're pre-dialysis. And of course, as the last year has shown us, we can't be involved, especially as transplant recipients. We're at really high risk, and so we're not in the hospitals anymore, and we pivoted and moved to a virtual environment. And so we did and I'm one of the coordinators of the program, but we did the research and found out what was the best program for us to adapt or to adopt. And we had some resistance from the QI teams and the teams at the hospitals because they weren't there yet, and they were still trying to negotiate, and some were still uncomfortable, didn't know what their communications or security or anything like that were at. So and some of them were like, oh yeah, let's do it, let's keep the communication going for our patients, because it's been really helpful for them. And it's not that there's not a lack of willingness to support the patients in their care, but it came down to, I think, being comfortable with the technology and being comfortable with
Oh. I think we just lost Mary momentarily.
No, I'm back.
Oh, you're
I'm
back.
back.
Okay.
I have rural internet. My apologies.
No problem.
But yeah, I think it was just even from their own individual aspects in terms of adapting to the culture of going virtual. I mean, that's something they've never had to do before. So it was really trying to meet everybody where they were at, and it took a lot of time. Again, that trust, that building relationships. We were having to do it with staff too, to get their buy-in, and we went with Zoom Medical, and and we had to explain to them, no, it's not just regular Zoom that people are talking to people, to each other, in their private lives or whatnot. It's encrypted, it's compliant with, PIPEDA, things like that. So we really had to sell it. And I think it's going to be a part of our reality. I mean, we still want to be in center, but at the same time too, I think it's going to be part of our reality.
Yeah, I mean, I think that this whole virtual thing could be a whole different discussion. So you've raised some really important points about the challenge of change in a lot of these things, but also really, I think what we've learned over the past year is that change is possible, and I hope it doesn't take another pandemic to keep more change coming. So I'm going to move to a last question for you, and I'm actually going to combine a couple of these here and really just ask about, can we get to accountability, and does this work in rural areas? And I do think that those two may be related, because we have to think about accountability given a given context, and there may be additional challenges for the rural places. So Tim, I'll turn it to you first, and then I'll ask Mary if she wants to have any final comments.
Yeah, okay, so two things. Of course, we can't ignore accountability because we are talking about public money in the health system. That's the first thing. However, having said that, accountability entails precision. It's an accounting term. It comes from accounting. It means, you can laser-like pinpoint who's responsible, who's accountable for what at any time. If we think of it that way, it's not going to be helpful. And if we, because what it does is puts people on the defense. And there may be some areas where that's appropriate, but in the sort of things where integrated care is at stake, and I think requires interorganisational collaboration, I would much prefer people use the word responsibility to accountability, because that suits a more mutual setting. And in saying that, you have responsibilities to each other, and you have all sorts of responsibilities to people. It's a wider term. Accountability is a very narrow term, and if we think in terms of accountability, and we can't not think in terms of accountability, we will lose so much. And on the remote areas, sorry, I don't have much to say on that, given that New Zealand, nobody is more than sort of an hour and a half away from a major hospital. So look to Australia, I think, if you want a buddy there.
Fair point.
Sorry.
Thank you so much. And Mary?
Yeah, I agree with the idea of responsibility, because I mean, the question is, can we get to accountability? What are we accountable for? How are you defining that accountability? I think responsibility, speaks less to that precise numbers and figures and pinpointing than it speaks more to maybe a bit more of the soft skills and things. And I think responsibility will probably take people out of their comfort zone, but I think it's a more helpful way once you start to, again, it's about building relationships, it's about building trust. And the thing is, we're all used to that way of accountability where it's that, you tick the boxes, and it's, it's all so precise and finite that way. But I mean, with responsibility, it's an ongoing thing, and it can fluctuate based on what's going on. Oh, and the other part in regards to integrated care with Canada's north, I'm just thinking, even just rural remote. I don't think it can exist without some sort of network or integrated care. I think it really, when you get into situations like that too, when you're in the north, you're limited to your resources, and you're limited to, you know, to how you can execute things. So you're always relying on other people. There's a lot of informal networks, and there's a lot of informal, you know, connections, and I think that's, unfortunately, or fortunately or unfortunately, that's part of the nature of it. You can't be a silo when you're going into a northern community. It's just not going to work, and you end up having to depend on the networks that you have up there as well.
I really love the way you framed your comments, really both of you, around integrated care really being relationship-based care. And if we move away from the idea of accountability, we can really underline and emphasize that the importance of those relationships. In this case, we're talking about interorganizational relationships as much as person-to-person relationships, but I think we all know that the well, Tim, you said it, the interorganizational stuff happens because of personal relationships between people in those different organizations. And I keep thinking about the adage, an old IT adage, which is that we really need to think about integrated care being baked in rather than painted on. And right now, it just sounds like we're trying to paint things or glue things together rather than building them from the beginning to be integrated. So I think you've given us an awful lot to think about. Thank you so much for your presentations and for the conversation afterwards. It's really been a terrific session. So now we're going to have a break, and we'll come back at 2:35 for the next session. Thank you, everybody.
Thank you.